Good afternoon. Welcome. Today's Grand Rounds are being brought to you by the Center for Christian Bioethics here at Loma Linda University. I'm the director, Gerald Winslow, and a special welcome to guests who are here for one of the early meetings of a new organization, the Inland Southern California Bioethics Consortium. We welcome you especially to our campus today and are glad to host you here for your event, which incorporates our Grand Rounds here today. If you would like to visit our website, which is given there as the address, you can see that, bioethics.lu.edu, you will find eventually archives of today's presentations and other presentations we've given here, including our recent Provencal lecture. You'll also discover that there's an upcoming webinar next week on the difference between ethics committees and clinical consultation and how they relate. And you may want to attend that. It's free of charge. All you have to do is just register right there, and you will find out about that opportunity. We also have a national conference coming up next month. You can also learn about it. It will be May 6 and 7, just to the north of us in Roseville, California, and some of you may have a special interest in that conference. It's a short airplane ride up to Sacramento and then over to the venue. In a brand new conference center. Our Grand Rounds today are brought to us by Dr. Grace Wee. Dr. Wee is a pediatric intensivist who did her medical degree here at Loma Linda. She has a fellowship in her area as well. In addition to her MD, she has a graduate degree in ethics. And she is the director of our clinical ethics program here for Loma Linda University Health, where she leads a team of clinical ethicists that provide our consultation service. She is also the associate director of the Center for Christian Bioethics, and thus my colleague in that role. And I want you to help me welcome Dr. Wee to this talk.
Good afternoon. Thank you so much, Dr. Winslow. Thank you for all of you who have come to spend a little bit of time with us today. I want to say that I don't have any financial disclosures or conflicts of interest. I do have some ethical conflicts of interest that may become a little bit more apparent, but no financial disclosures. For our time today, these are the objectives for this talk. We're going to talk about the right to try laws, the laws that have been passed. There's a recent federal law that was passed and the state laws that have been passed. And this is regarding a patient's right to experimental therapies. We're going to analyze the ethical conflicts and evaluate potential impact of how these laws, how they can affect public health, clinical trials, and the development of novel therapeutics. First of all, who has seen this movie? Good. Yeah, so this is a shot from Dallas Buyers Club. This is a film that was released in 2013, and this movie was based on a magazine article that was written in 1992 by Bill Munutaglio. And this is about a man named Ron Woodruff. And just for a clarification, Ron Woodruff is being played by Matthew McConaughey, and he is the gentleman in the white cowboy hat. Ron was diagnosed as HIV positive in 1986, or according to other sources, perhaps earlier than that. But around 1987 or 1988, again, depending on the source that you read, Ron started the Dallas Buyers Club. This was one of several underground organizations that smuggled non-FDA approved medications from other countries into the U.S. These buyers clubs focused on obtaining and delivering to its customers promising but yet unapproved treatments for HIV and AIDS that were available in the foreign markets. These are drugs such as clarithromycin or DDC or interferon alpha. And customers took these medications at their own risk. One drug that the movie focused on was peptide T, a medication that's currently not available for human use. Peptide T was discovered in 1986, and it was thought to be a promising drug to reduce the cognitive decline associated with HIV. Buyers clubs started distributing peptide T. And Ron Woodruff actually became a big user of this medication. In 1990, the U.S. government banned foreign companies from shipping peptide T to the U.S., and Ron Woodruff sued. He sued the FDA. He lost his suit, but arranged with the FDA to continue to have personal access to the drug. At the same time that Ron was suing the FDA, and then while he was receiving peptide T under a compassion use exemption, there was a double-blinded placebo-controlled clinical trial that was being undertaken to determine the efficacy of peptide T. Ultimately, there was found to be no statistical difference between the peptide T group and the placebo group. But let's get back to Ron. His efforts to obtain this medication sounds extraordinary, and it certainly makes for a good movie script, especially if you can be portrayed by Matthew McConaughey. And by the way, to be clear, I am not vouching for the veracity of the movie. What I do think the movie does well is portray the significant stigma associated with the treatment of HIV and AIDS in the 1980s, along with the high mortality rate associated with the disease. People with AIDS and their families were living with fear of the disease. They were angry at the perceived slow pace of treatment, and they were desperate to find something, anything, that would extend their lives, even if they had to do it themselves. This quote from this article is from Bill Hunt, and he's a Dallas Buyers Club customer, and I think this quote sums it up well. He said, "We live in a country where politicians and others won't even support prevention programs that will save their own kids' lives. Against that landscape, do they care about people who already have AIDS, who happen to be expendable, who happen to be an expendable population? We created the institutions, the buyers clubs, all across the country, not because we were so smart and knew what we needed and knew that we needed them. We created them because nobody else is going to do it for us." In this quote, you get the palpable sense of the existential crisis. The sobering history of HIV/AIDS, of the epidemic in America, is filled with stories of patients, families, doctors desperately seeking treatment outside of the system. And to its credit, the FDA during this time period began working with the HIV/AIDS community to expedite the review of drugs. AZT, the first treatment for HIV, went through the process of patent to approval in 25 months. This was and is still extraordinarily fast. However, we should also note that this would be 25 months too late for many patients. If you're interested, this complex story is told well in this book, The Epidemic by Jonathan Engel. This book certainly brings much more of a balanced view to buyers clubs, the FDA, and the politics of AIDS and HIV than does the movie. But let's fast forward 30 years later. HIV treatment is now commonplace. Are there still patients who are dying, desperately waiting for treatment? Patients who are stymied by the FDA? Do patients still need buyers clubs? How many of you have seen this? So this is a HEC-C buyers club. And this was established in response to, does anybody know the drug? That's right, Harvoni. So undoubtedly, or maybe you've probably seen this medication, like advertisements for this medication, or even seen its beautifully shot TV ads. Harvoni is the first curative treatment approved for hepatitis C. And interestingly enough, the HEC-C Buyers Club was formed not in response to the FDA, but the company who discovered and is marketing Harvoni, Gilead Sciences. And this is because Gilead Sciences has priced Harvoni at $1,000 per pill for a total treatment cost of $94,500. So the CDC estimates 2.4 million Americans are living with hepatitis C. Half may not know they're infected. If everybody was treated with the $1,000 a pill Harvoni, it would cost $226.8 billion. By way of comparison, the Centers for Medicare and Medicaid Services, or CMS, estimates that in 2017, total prescription drug spending was $333 billion. That's a lot of money that Harvoni is making for Gilead Sciences. So yeah, it seems that perhaps there is still a need for a buyer's club. And for the record, this website can help you buy a generic version of Harvoni for the total treatment cost of between $1,200 to $1,500. That is the price of 1.5 tabs. You can even participate in a clinical trial comparing the efficacy of Harvoni with the generic medication. So, it seems, there are still several obstacles that are blocking patients from receiving efficacious or potentially efficacious treatment. Obstacles such as stringent government regulation and the market-based strategy of medication pricing. But in this complex debate, how much of a stumbling block is the FDA and its approval process? Can patients' lives be saved simply by access to experimental drugs? I mean, who doesn't want to save patients' lives? If only there were a way to ensure access to these experimental drugs. Well, in 2006, the D.C. Court of Appeals was faced with deciding the legal version of this question. And the question is whether a person has a constitutionally protected right to potentially life-saving investigational therapies. The argument that this is a constitutionally protected right is not new. And in fact, Ron Woodruff used this same argument in his lawsuit against the FDA in 1990. But the Court of Appeals ruled in 2006 that there is no such right for a terminally ill patient to access experimental drugs that have passed limited safety trials but have not proven to be safe and effective. After this, the Goldwater Institute, a libertarian think tank based in Arizona, became the chief advocate to pass right-to-try laws in all 50 states to allow terminally ill patients access to investigational drugs. In fact, the Goldwater Institute wrote the model legislation on which the majority of the state and federal right-to-try legislation is based. They also provide patients with sample letters to write to companies in order to try to access medication. And they've been extraordinarily successful. To date, right-to-try laws have been passed in 41 states, and these are the states in green, including, as you can see, California. California's right-to-try law was passed in 2016, 1 year after a similar bill was vetoed by then-Governor Jerry Brown. This is an enormous legislative effort. I do wonder, however, if the Goldwater Institute, in its zeal to improve access to therapy for patients, would support a right to Harvoni bill. But I digress. So let's get back to the legislative success of right-to-try laws. On May 30, 2018, President Trump signed the Trickett, Wendler, Frank Mongiello, Jordan McLinn, and Matthew Bellina Right-to-Try Act of 2017. This is a still shot from the signing ceremony on that day. So this is a federal law that allows pharmaceutical companies to provide a terminally ill patient who has exhausted approved treatment options and is unable to participate in a clinical trial involving these drugs, the use of investigational and unapproved drugs. So what does this mean for the patient? How is it different from the compassionate use exception programs that the FDA already has in place? Can a patient demand treatment? Does this bill save patients' lives by allowing them to access medications that are being blocked by the FDA? Well, we look a little bit deeper into the law. There are patient eligibility criteria and drug eligibility criteria. The patient eligibility criteria we just touched on briefly. Again, you must have a terminal illness. You must have exhausted all your treatment options. You cannot, and you are not eligible to participate in a clinical trial. And then you also have to provide written informed consent. On the drug side, the drug must have completed a phase 1 study. It cannot be approved or licensed for any other use. It has to be in active development or production, and it must be under investigation in a clinical trial. Unlike some of the state legislation, this federal law only covers drugs. It does not cover investigational devices. There are some limitations. The drug is subject to certain labeling requirements. It cannot be promoted as being approved prior to FDA approval actually being obtained. And the cost is limited to the direct cost of making the drug available to the patient, i.e., the drug company cannot profit from providing the drug to the patient. However, the legislation does not have any language about whether the physician who is prescribing the medication can charge additional fees for their services. What about clinical outcomes? What happens if the patient suffers an adverse event? Well, any clinical outcome cannot be used to impact the review or the approval of the drug, unless the drug company requests the outcome data to be included in the application for review, or there's a clinical outcome that is so critical to determining the safety of the drug that the FDA head and the Secretary of Health and Human Services must now report the clinical outcome. What about reporting? Well, the drug companies must report to the FDA who they give it to, the drug, the dose, the number of patients that are treated, and any serious adverse effects. However, the law does also state that no liability should come against the drug manufacturer, the prescriber, or the dispenser. And at the bottom of the bill, there is very clearly stated that there is no mandate to provide the drug. This, and this is a direct quote, does not establish a positive right to any party or individual. This is intended to be a separate mechanism for access from the already existing FDA mechanisms for expanded or compassionate use. And it significantly reduces the regulatory burden by not including the FDA into the process of acquiring the experimental drug. So we've talked a little bit peripherally about the FDA. Maybe this is a really good time right now to dive a little bit deeper into the approval process that the FDA goes through. So this is very brief. After a promising drug is developed, it undergoes laboratory and animal testing to determine safety. These studies provide information on dosing and toxicity, and based on this information, researchers then determine whether to go forward with human testing. In the clinical research stage, drugs undergo clinical trials in 3 phases. In phase 1, the drug is studied in humans for dosing and safety, with the dosing schemes that were based off of the animal studies. This is a small trial, generally under 100 people. And because of the small nature of the trial, rare side effects are likely not going to occur. The phase 2 trial will be done on a larger number of people to provide additional safety data. And then after phase 2, a phase 3 trial will be done to determine whether the drug actually offers a treatment benefit to the targeted population. Per the FDA, approximately 70% of drugs will move from phase 1 to phase 2, and approximately 33% of drugs will move from phase 2 to phase 3. Phase 3 by itself is estimated to take between 1 to 4 years. After the clinical research is completed, the FDA will then review the data and then issue a ruling on whether the drug is going to be approved. If the drug is approved, the FDA continues to monitor the drug in a phase 4 studies or post-market trials, and this is done after the drug is brought to market. This is a laborious and intensive process, and it's also very expensive. So the cost of R&D to get a drug to market is estimated to be $2.6 billion. This includes the cost of other medications that did not make it through this process. The post-approval R&D costs increased this estimate to almost $2.9 billion for one drug. So perhaps we shouldn't begrudge the makers of Harvoni their $1,000 per pill. But getting back to the right to try law. Now patients do not have to wait the estimated 5 to 10 years for a drug to be brought to market. thanks to right to try laws, patients can access drugs directly after a phase 1 trial, cutting out the years of research that is needed before the drug, even if it makes it, is brought to market. And this sounds like a great idea. And in fact, the FDA already has programs in place for expanded access to experimental drugs for just this patient population. The Expanded Access Program, or Compassionate Access Program, covers both drugs and investigational devices. And this is the program that allowed Ron Woodruff to continue taking peptide T after losing his lawsuit against the FDA. So what is this Expanded Access, or EA, program? It allows patients and physicians to work with the pharmaceutical or device company to provide access to drugs and devices outside of clinical trials when no comparable or satisfactory alternative therapy options are available. Eligible patients are those with an immediate life-threatening condition or a serious disease. Now, if this sounds very much like the eligibility criteria for the right to try laws, you would be correct. It is the same eligibility as the right to try laws. The FDA not only provides individual patients with the option of expanded access, it also allows for groups of patients to access the investigational drug. And for individuals, there is an emergency use option that allows for treatment to begin prior to approval being obtained. The approval process requires that the following people and entities be involved: the patient, the physician, and the physician is responsible for filing paperwork with the FDA and the IRB, for working with the company to access the drug, and for providing patient care. The company. This is a company that provides the drug, works with the FDA on oversight and reporting of serious adverse effects. The IRB. This is the IRB of the institution that the physician practices in, and the IRB is charged with protecting the rights and the welfare of the patient and for ensuring informed consent has been obtained. And then finally, the FDA, which reviews the EA request and determines whether the request should be allowed to proceed. So under this rubric, in 2017, the FDA approved 99.4% of all requests by individuals and groups for access to drugs and biologics under the Expanded Access Program. This is just the 2017 number that I'm showing you. For the years 2009 to 2017, the FDA approved 99% of all applications. It's pretty good. So given this model, which has, again, a 99% approval rate for extended use, why would a libertarian think tank put such enormous effort into passing right-to-try laws, both state by state and federally, an act that essentially does the same thing as current practice, but cuts out the roles of an institutional IRB and the FDA, two entities that exist to protect the patient? Why so much effort into an act that does not require the company to provide the investigational drug at all, but should the company provide the drug, actually releases the company of all liability should something happen to the patient? This doesn't sound like right to try or right to get. This sounds like right to ask, and it sounds like the pharmaceutical companies have a right to say no. So then, why are these bills so popular? I think this brings us back to the larger philosophical debate between the interest of the individual and the interest of the larger players in our society, such as government, the pharmaceutical industry, and yes, even political parties. This is perhaps because right-to-try laws seem written with a certain philosophical mindset. And I don't think we can understand this law without spending some time thinking about the role of the FDA and also, briefly, libertarian political philosophy. But first, let's address the role of the FDA. The role of the FDA is safety and efficacy. And its role in monitoring safety as we know it started in 1937. When a pharmaceutical company created a formulation for an antimicrobial drug by dissolving it in diethylene glycol, then a popular solvent. If you think, oh, that sounds familiar, yes, that's because it's highly toxic and it used to be a chief component of antifreeze. The chief chemist added raspberry flavoring to this new drug formulation, and the drug was marketed as elixir sulfonilamide. And the toxicity of diethylene glycol was not known at the time because no drug testing was required prior to the drug being brought to market. At least 100 deaths were blamed on this medication, including the deaths of children, and in 1938, the Food, Drug, and Cosmetic Act was passed, which required pre-market proof of safety. But even after this, efficacy was not really within the purview of the FDA until in the 1960s, the drug amendments of 1962 was passed in response to the thalidomide tragedy. So the thalidomide was approved overseas, but approval was being held up in the U.S. And the FDA physician scientist who held up the approval of the drug, this is a picture of her, Frances O. Kelsey, went on to receive the President's Award for Distinguished Federal Civilian Service by JFK, becoming only the second woman thus honored. So it's perhaps this history that has led the FDA to adopting an overly conservative approach to risk assessment. Now, there's no question that there exists significant ethical tension between the medical needs and wants of the public and the charge to the FDA to ensure safety and efficacy of available drugs. And I think there are two main ethical tensions that we should dive into today. First is paternalism versus autonomy, and the second is individual-level decisions versus population-level decisions. And this is where we ever so briefly talk about libertarian philosophy. So let's dive into the first tension, paternalism versus autonomy. This is not new. And in fact, this is probably the most recurrent theme of American medicine. Patients desire the ability to determine the course of their own medical treatment in accordance to their goals and values. And by requiring testing and demonstrations of efficacy, the government is infringing on the right of the patient to determine for herself or himself whether he is able to accept the risk that is associated with taking an experimental drug. Now, proponents of this view may want to expound on the political theory of negative and positive rights. Negative rights are those that do not impose a duty on others to provide something to you. Positive rights, on the other hand, impose a duty on another person. Proponents of libertarian philosophy are likely to point out that the most fundamental of all rights are actually negative rights. For example, the First Amendment, the right to free speech, is more properly a negative right. It is the right to speak without government interference. Patient autonomy can be thought of similarly. Negative autonomy is the right to decline any and all therapy. Positive autonomy is more restricted. It is the right of a patient to have or to request treatment. A right to try law, properly grounded in libertarian theory, is simply then the right of the patient to request treatment without interference from the government or anybody else, or i.e., the FDA and the IRB. But does right to try impose positive rights on society or pharmaceutical companies? No. In fact, it's pretty internally consistent. It absolves pharmaceutical companies of all liability. In some states, the laws take it even a step further. Again, this law states that the patient has the right to ask for experimental treatment free from interference. And if the patient does receive the experimental treatment, the law further exempts certain parties from any imposed obligation or responsibility that may come from the use of the experimental therapy. These exemptions include, in certain state laws, the obligation to provide health care coverage. So let's look at Colorado's right to try law, which was the first law to pass in 2014. Colorado's right to try law includes a clause that allows insurers to deny health care coverage to the patient from the time he or she begins experimental treatment to up to 6 months after the discontinuation of the treatment. Now, admittedly, this is vague language. An insurer may deny coverage to an eligible patient. It is not clear whether the law refers to coverage of the condition in general, or the conditions incurred by the use of the experimental therapy, or health care coverage in general. But it could mean that the terminally ill patient can be denied health care insurance if he or she chooses to pursue experimental treatment. I gotta say that at least this law is philosophically consistent. I mean, I don't think there's any plainer way to carry out the concepts of negative autonomy to its logical conclusion than by allowing the denial of terminally ill patients' health care coverage. And that is, I think, the problem with the libertarian take on patient autonomy, because none of us is an island. If the patient who now has no health care insurance because he has taken a drug under the right to try law requires aid, who of us will refuse to help the patient in the face of suffering? Now, proponents of autonomy will reply, well, if you choose to help, it is a choice you take upon yourself. It's not a duty that is required by the law. And to which I would probably say, well, this law seems to rely an awful lot on the non-compensated intrinsic goodness of people to help out those around them who are suffering. This seems to be a pretty tough way to live. Right to try laws seem to be less about personal autonomy and more about shifting responsibility from public interest organizations and the pharmaceutical companies to the individual and people around the individual who care enough to help. But I think this divide between paternalism and autonomy is outdated, and it needs to be rethought. Patients have a legitimate interest in making decisions that are consistent with their lived and stated values. And government also has a legitimate interest in ensuring the safety and efficacy of medications that are brought to market. And perhaps a better way is to bring the two interests together by investing in the current system to make it more responsive to the needs of society. This occurred in the 1980s during the HIV/AIDS epidemic, when the approval cycle was drastically shortened in response to overwhelming medical need. And it's occurring now. This push to pass right-to-try laws prompted the FDA in 2015 and 2016 to reduce and simplify the paperwork associated with the expanded access program. There was one documented incident that it took a physician 100 hours to fill out the paperwork in order to get a patient into his expanded access program. There is further documentation that this process has been streamlined, and so that the paperwork can now be filled out, and the estimated time is about an hour. In 2018, the FDA publicly affirmed again its commitment to strengthen its expanded access program. And publicity surrounding right-to-try laws likely have increased awareness of the FDA's program, a good that perhaps could not have been accomplished any other way. The second ethical tension that I want to address is when the interest of the individual conflicts with the interest of the population. Right-to-try success stories are usually about an individual who personally has had clinical success with the use of a drug, regardless of the studies designed to measure efficacy. An example would be Ron and his use of peptide T, in which he personally experienced a good clinical outcome, even though statistically peptide T was no more efficacious than placebo. These individual stories are moving, and they may lead one to ask, why shouldn't approval be granted for drugs that show small-scale promise? Wouldn't this save lives? Another way to think about this is to think about this in terms of type 1 and type 2 error. Type 1 error is when the FDA approves an ineffective therapy. A type 2 error is when the FDA would reject an effective therapy. The consequences of a type 1 error is long-lasting. The difficulties of post-market analysis of approved drugs restricts the FDA's ability to correct a type 1 error. It does do it, but it's more difficult. However, the more the FDA tries to avoid a type 1 error, the more it risks committing a type 2 error. And the fear of the type 2 error is probably the most compelling ethical argument for right-to-try laws. Both errors are costly, but committing a type 2 error is personally and emotionally taxing. This patient could have been saved, but for the too rigid approval process. What did the patient have to lose anyway? He was going to die. So let's turn to some statistics to help flesh out this problem. This is a quite interesting article that was published in Nature Biotechnology, and this details the success rate of the development of medications across the pharmaceutical industry. And it examined 835 drug makers between the years of 2003 and 2011. The authors estimated the success rate of making it through each phase and calculated the likelihood of obtaining FDA approval. This is a graph. It's very dense. I don't expect you to read it, so I blew up the pertinent statistic here. LOA is likelihood of approval. This is the calculated likelihood of obtaining FDA approval for drugs in phase 1 development. So this is any drug, phase 1 development. The likelihood of obtaining FDA approval is 10.4%. Here is the likelihood of approval for drugs who are in phase 2. 16.2%. Phase 3, 50%. Finally, drugs who are under active FDA review, 83.2%. The numbers in the middle, 32.4%, for example, 60.1%, and 83.2%, this is the rate of success of a drug moving between phase 2 to phase 3. So 61%, this is the rate of success of a drug moving from phase 3 into the under approval, or the review process. That's what NDA/BLA, this is the review process that the FDA undergoes. So it seems that from these statistics, again, let's go back to the 10.4%, the 16.2%, et cetera. It seems that these statistics that each phase is designed to avoid a type 1 error, that is approving an ineffective drug. And we can see that by the high fallout of these medications. Many of these drugs fail to advance because they do not demonstrate adequate efficacy. Where in this process is the type 2 error occurring? I think it's occurring in the determination of the threshold efficacy that must be shown before a drug can be advanced. How efficacious does a drug have to be if the alternative is certain death? It would seem then that the drug approval process should take into account the likelihood of death of the disease itself. For example, the efficacy threshold of a medication to treat toenail fungus should be way higher than the efficacy threshold for a new drug to treat, say, cholangiocarcinoma. This is the cancer that my father passed away from in April of 2014. As an aside, the 5-year survival rate from my dad's cancer, metastatic intrahepatic cholangiocarcinoma, is 2%. Perhaps a good way to balance the ethical tension between type 1 and type 2 errors is to accept drugs with a higher risk of being ineffective, specifically for diseases that are particularly lethal, in order to reduce the risk of bypassing effective drugs. And this is exactly what was proposed in a recent article published in JAMA Oncology. So, right to try laws, or the FDA's expanded access program, or even buyers clubs. Will these programs address type 2 errors? Not effectively, because this needs to be done by adjusting our research protocols. Thus, the most compelling ethical argument for the right to try law is actually an argument for revising and strengthening existing research protocols. There are other ethical concerns about right to try laws, and for good measure buyers clubs. There is a reduced role for the structures that are in place to advocate for patient safety, such as the IRB. Now, the IRB's purpose is to protect the rights and welfares of human research subjects, and one way it does this is to oversee the informed consent process. The informed consent process is a vital part of any program that does research or offers experimental therapy. Prior to enrolling into a trial, researchers are ethically bound to ensure that the patient understands the risks and potential benefits of the trial. But can informed consent be truly obtained when the risks of an experimental therapy are unknown? Is it enough just to tell the patient that there are unknown unknowns? How does one comprehend this? particularly a patient who feels as if taking on the unknown is the only treatment option. Is there a free choice in this instance? When obtaining consent for an experimental treatment, the knowns then become much more important. And the knowns are the structures that are in place to mitigate this unknown risk. These include, for example, the robustness of the monitoring program to detect and manage adverse events, the ability of the treating physician and the institution to respond to and to manage these adverse events, the presence of a program to scrutinize for potential clinician or systematic biases that may inadvertently increase the risk to the patient, or the institution's and the physician's commitment to oversight and reporting. These structures and systems are typically managed by the IRB. So I really question whether patients have enough information to provide informed consent, whether their informed consent is truly a choice, or whether adequate risk mitigation can be done without prescribed oversight. So now we've come back to the question that brought us here earlier. Do patients have the right to experimental therapies outside of the standard process, either through right to try or through buyers clubs? In our past few minutes together, we've talked about why patients might want to try experimental therapies. We've talked about the law itself and its philosophical basis. We've talked about the ethical tensions inherent in right to try laws and other significant ethical concerns. So, what is our conclusion? My conclusion: yes, but through a better way than right to laws. Absolutely, patients have a right to experimental therapies, but in a way that safeguards them through existing mechanisms such as the FDA or the IRB. Patients have the right to experimental therapies in a way that allows patients and regulatory agencies to work together towards common interest. And yes, patients have a right to experimental therapies in a way that acknowledges differences in medical needs. Patients have a right to experimental therapies not because of the U.S. Constitution or Goldwater Institute or the state or federal legislation. Patients have a right to experimental therapies because we are human, and health is a universal human right, and experimental therapies in its small way contribute towards health. But so also does access to health care. We cannot abstract one person's right to experimental therapy from the society and the reality in which we live in, because the right to experimental treatment comes from a just society. I would argue that right to try laws do not make our society more just, but the presence of such laws has spurred needed conversation, and this type of conversation can, I believe, move us towards making decisions to create a more just society. So what does that society look like? Well, for starters, it's a society that does not have expendable populations, or pass laws to allow denial of health care coverage, or advocate for philosophically empty laws. I want to close with the same quote from Bill Hunt. Let's work together to make our society one that commits to caring for the least of these, not because the law commands it, but because it is a duty born from our shared humanity. Thank you. I am happy to take questions. Sure, that would be great. By the way, I do also want to add, I mentioned my dad, and I want to mention him today. So, he was my first ethics teacher.
So we have time for a few questions, and I can't imagine that a provocative talk like that didn't generate some questions or comments. So let's see what we have here from anyone who wants to ask or comment. Oh, I'm sorry, right there. Please.
I don't know if you found in your research, are there particular ailments that tend to draw people in more than others that try to access treatments under these right to try laws? Are there certain skin conditions and cancer? Is there sort of kind of a bucket that more of them tend to fall into?
So the information on who is accessing the right to try laws actually is very, very limited because the reporting is so limited. Now that the federal law has passed, we may be getting more information of who is accessing right to try. There is a website put on by the Goldwater Institute. It's called righttotry.org or righttotry.com. I mean, if you just Google right to try, it'll bring you to this website. And it does list people who have accessed this law. And it seems that there is a certain group of patients with a neuroendocrine cancer who have accessed experimental therapies based on right to try.
Dr. Lewis.
Any comments on right to try for controlled substances? Probably the various cannabis derivatives would be the ones that come up first.
Yeah, so in order for a drug to qualify for right to try, it has to not have been approved for another use, and it has to be under active investigation, and it has to have passed a phase 1 study. So if that compound meets all of the requirements, it should be accessible through.
So like morphine Schedule 2, all of the schedules are applied after approval. So if there's an opioid under development, it would meet those criteria.
If it's under development, if it's gone through phase 1, yeah, so no prior approval for, I mean, that was the key thing, no prior approval.
So even if there's a risk of it being controlled, it would.
I did not run into anything in my research specifically about controlled substance. I did about marijuana, and there was specific language about the formulation of cannabis or CBD or whatever that compound is. It has to be distinct enough so that it is a new investigational drug.
But would it meet the criteria? I'm just thinking of some recent work we did on psilocybin, which is a psychedelic drug, and it is under investigation, but would it meet the criterion of the person being terminally ill? Because in most cases, what's being investigated for is not that.
So the terminally ill designation is something that's certified by your physician.
You said that with a little nod and a wink, like just get your doctor to say so, I guess. All right. Other questions? Jim?
Grace, could you say more about the value to the individual under expanded access provisions versus the protection of the population as a whole? How far should we go in letting individuals have access that they want if it is a threat to the confidence of the population in the whole regulatory process?
So, thank you for your question. So when you say the confidence of the population in the whole regulatory process, this would indicate that the population as a whole feels that the regulatory process is too stringent? Is that?
I'm thinking that if there were bad outcomes that the expanded access did allow, because it gives more freedom for the individual with less of a process before the drug is available. Correct.
Right.
And that boomerangs, and we have bad outcomes, and it starts to affect the population in general and their confidence in the drugs they get at Walgreens.
Yeah. So I would answer that in a couple of ways. The first thing is that there are very rarely stories that are told of patients who access drugs through right to try who then go on to have a bad outcome. These stories are not publicized. In fact, it's more the stories of patients who are doing well because they have accessed these medications. But I agree that patients who access experimental therapies who are doing so outside of a IRB protocol or an FDA or some sort of protocol where there's oversight, it can be dangerous because we don't know what these clinical outcomes are for these patients who are accessing the drugs under right to try. The companies are only required to report to the FDA yearly serious adverse events. There's no definition. I mean, there's a standard clinical definition for serious adverse events, but there's no other definition of what constitutes a serious adverse event. clinical outcomes that are then reported to the FDA cannot be used in its approval process of the drug itself, unless the company actually says, oh, I want to pull in all of these outcomes because they're so good, and this will probably enhance the approval. But if the clinical outcomes are bad, they cannot be used to impact the approval process unless the Secretary of the Health and Human Services and the head of the FDA determine that these clinical outcomes are critical to the approval process itself. If they do determine it's critical to the approval process itself, they must file a public notice that they so feel this way and give the company a chance to respond in kind. And I mean, that's clearly stated in the law. So yes, I agree. I think there is danger of having patients participate or receive these experimental drugs without an appropriate mechanism for their clinical outcomes to be incorporated into the general knowledge of the drug.
My question that seemed kind of obvious as you went through the presentation, if it's true that over 99% of the requests for compassionate use are being approved, what is the big drive then to have these additional right to try laws? Is it because, yeah, they're approved at 99-point-something%, but it's just too cumbersome?
So that's probably the biggest. That's probably the biggest point that the Right to Try website will bring up. They will say the paperwork, the regulatory process is so onerous, it's so cumbersome that it really, in and of itself, will restrict patients' access to experimental drugs.
Maybe one or two last questions before we run out of time. Dr. Moore.
So, Grace, it seems like folks who advocate for things like right to try do not necessarily believe in your apparent belief that healthcare is a right is not a universally held belief in this country. And in fact, if you look at the Supreme Court when they were looking at Oregon's Death with Dignity Act back 20 years ago, the Supreme Court said you do not have a right to physician aid and dying, but you have a right to palliative care, which I don't know how you get when you don't have a right to healthcare.
Yes. You know, I'm glad you brought up palliative care in hospice. So in 6 states, I believe it's 6, in 6 states, out of the 41 that have passed laws, 6 states, in their laws, there is a clause that allows insurance companies to deny hospice and palliative care services to patients who are accessing experimental drugs through right to try. And again, these are vaguely worded laws. So going back to Colorado's law, you know, you have you can deny health care coverage to eligible patients. I mean, what does that mean? I mean, the devil is in the details, but yes, I would agree that there is some concern in the fact that we are passing laws to allow patients to ask for an experimental medication, but expecting them at the same time to be okay with not having healthcare coverage for the remainder of their illnesses.
Yes, right.
That doesn't really prevent them from going to like ER or anything, though, right? But then does it cause problems in terms of like placement afterwards for like the hospital teams? Can you repeat that?
So the question is, it doesn't prevent them from going to the ER. That's correct. But then does it cause problems for placement afterwards? Yes, absolutely. I mean, it's hard to access any sort of services if you don't have healthcare insurance. There are state laws. So there are a number of advocacy websites that actually look at all of the text of these bills. And so there are some state laws that restrict hospice and palliative care. There are some state laws that actually restrict home health services if you access right to try laws. So if you don't have health insurance or you can't have home health coverage, it's really hard to find health care if you are terminally ill and all other treatment options are closed to you, and that's exactly why you are accessing experimental drugs.
Yes, in the back.
So it sounds like if you're going to give up your right to health care, try these drugs, it's going to cause an underground economy for these clubs again to bring in drugs that don't go through the system. sounds like, because who's going to do that? Why not? It's such a catch-22.
Yeah, I think this is really an argument for the FDA to look at its approval process. I mean, I'm really serious about refining the protocols of efficacy thresholds, because I think that is going to be the biggest step to go towards eliminating the need for underground buyers clubs. People are going to buyers clubs because they can't access these drugs. They don't see a way to access these drugs anywhere else. But if the FDA, through its expanded access program and through also being able to say, for this disease, since it's so lethal, we are going to lower the efficacy threshold so that more drugs can make it through the pipeline and more drugs can be approved. I think that's going to go a long way towards curbing the development of underground buyers clubs. But that is only underground buyers clubs for drugs that are not approved. I think it's so interesting that the current most active buyers club is a buyers club to circumvent the medication pricing structure that's been put in place here in the U.S.
Thanks for mentioning that last part, because one little correction that I would make on what was said earlier is that Harvoni, which is really the trade name for sofosbuvir, was not developed by Gilead. It was developed by a little startup company that actually planned to market it for about $100 to $200 a pill. That molecule was bought by Gilead and then marketed for $1,000 a pill. This is the only society that lets that happen. It is widely used throughout Europe and so forth, but not at that price. So I think that you're going to see an increased political discussion in our society about why that's true. Because while they have to recover their R&D amount, do they have to recover, say, a $2 or $3 billion average input with $250 billion? That's really an ongoing political question. I feel like I used up the last 30 seconds. Anybody else? I just had to drop that in. All right. Thank you all for coming.